Welcome back to the Pudding Pals podcast, where the proof is in the pudding, and this pudding is thick.
Or pink.
Pink today. We are ending Breast Cancer Awareness Month, just like we started, but this time with some clinical advice from a wonderful physician.
Yes, Dr. Amani Jambhekar. She is a breast cancer surgeon, an educator, and a powerful advocate for empathy in medicine. And she has amazing TikToks and amazing advice, and we cannot wait to talk to her. But before we do, I just saw something.
What? It's sold out.
It's sold out. Skims underwear, or thong,
with
a hairy pussy.
hair vagina.
It's sold out. So I want to know who bought the hairy pussy.
Definitely you did.
I definitely have no hair. I wouldn't want hair.
I
I'm
feel
bald.
like we've all spent a lot of money on laser, and then you bring in this.
I know. It's a
much is
bush.
it?
It's a bush on the skin.
I know what I'm
$50,
getting you guys
$50.
all for the holidays.
You can. It's sold out.
Don't
There
worry, you
are-
can find anything. How do you
On
ever-
eBay, you want someone's dirty hairy pussy?
Whatnot? They're probably selling it all day on Whatnot.
Ew. Anyways,
How
you
much?
guys.
Do you know how much it costs?
60,
I don't
50?
know.
I don't know. Anyways, guys, we'll go from vaginas to boobs.
To boobs, yes.
To boobs.
All about women.
All about women.
Well, let's bring Dr. Jambhekar in, and let's get into it.
Let's get into it.
Welcome to the Pudding Pals podcast.
Dr. Jambhekar, welcome to the Pudding Pals podcast.
Thank you so much for having me on.
Of course, we are so excited to talk to you. Today is the last week of October, and we wanted to meet with you and talk about breast cancer, as it is Breast Cancer Awareness Month. So we'll get started, but first let me introduce you to people on the couch, the pals. This is Heather, myself, Danielle, Jordan, Ashley, and Steph. What drew you first to breast surgical oncology?
So I trained in New York and I did my general surgery residency there and really wanted to be in a field where I could make the focus of my career empowering women. And breast surgical oncology just seemed like the perfect fit. It's also a very evidence-based field, and there's constantly changing evidence to dictate how we do things. And I loved that about it as well.
Yeah, I love your TikToks.
Thank you.
I do. So let's talk about early detection. You know, we hear a lot about mammograms and self-exams, but what's your advice for women on like how to stay proactive and like what age to start?
Great question. So, the American College of Radiology actually recommends risk assessment for anyone who has a family history of breast or ovarian cancer by the age of 25. And so, I know, and that surprised me as well. That doesn't mean that at 25 you need to start doing things like mammograms, but it does mean that being aware of what your risk looks like and speaking to a breast surgical oncologist like me or someone else in a high-risk breast clinic is really important, because some of these younger women may benefit from things like MRIs starting at 25. Now, usually mammograms, we start at 40 for someone who's at average risk. So I think it's really important to start right at 40, get a mammogram every single year. But if you are someone who's high risk, then you may benefit from getting mammograms as well as MRIs starting at the age of 30.
And what does high risk mean?
Great question too. So high risk means that you have a greater than 20% lifetime risk of developing breast cancer. And there's a few different ways you can become high risk. So first, we kind of already talked about family history, but having a first degree relative, meaning like your mom or your sister that's had breast or ovarian cancer, usually does put people in that high risk category. But also if you've had biopsies of any kind that showed atypical cells, that usually puts people in the high risk category as well. And then some of these other risk factors, like if you have a gene mutation, that would put you definitely in the high risk breast category as well.
How would you just mentioned gene mutations, but the average person walking around doesn't know if they have a gene mutation.
Right.
So, barring a first degree relative, which is an obvious factor, do you recommend people like, I know insurance doesn't often cover genetic testing, it's expensive. Like, is that something people should do?
That is definitely an interesting point. The so insurances are a little bit finicky. You're right about what they cover in terms of genetic testing. And you do have to have a very solid family history of not just breast and ovarian, it could be other types of cancer like pancreatic cancer, prostate cancer, colon cancer, uterine cancer. And you could get covered depending on the criteria and kind of depending on your insurance coverage. If it were up to me, though, there wouldn't be any specific criteria that you have to meet, and everybody should be eligible for genetic testing because there are many, many times that I test patients because I'm thinking that their family history sounds like there's one gene mutation, and then I find something completely unrelated. So now the cost of genetic testing has gone down compared to what it was in the past. And I actually do have patients that come to me and say, you know what, I know that I don't have enough family history to meet those criteria, but I still would really like to get the genetic testing done. How much is it? And all of the companies that I've seen usually charge a maximum of $249 out of pocket. So it is actually kind of affordable. And I especially recommend it to people who are adopted or who maybe just don't know one side of the family history because they're just not in contact with that side of the family. I think it gives a lot of answers. And it can also kind of help quantify your risk as well. There's a certain company, Myriad Genetics, that actually will use something called single nucleotide polymorphisms, which are single base pair changes, little changes in the DNA that are kind of sprinkled in, and they can kind of predict who might be at increased risk or decreased risk. And I think that has been a huge innovation in the last decade or so to help women kind of understand what their risk is. But unfortunately, you can only get that calculated if you also get genetic testing and you meet criteria, or if you decide to pay for it out of pocket.
Question for you.
Sorry, go ahead.
So
Ashley.
I get genetic testing and I get told I'm at high risk for breast cancer. Now what?
So it depends on what your risk level is. So somebody who has, say, a 20%, 30% lifetime risk of breast cancer, then they may opt for something called enhanced surveillance, which is what I was talking about before, getting an MRI once a year as well as a mammogram once a year. And sometimes people choose to stagger those 6 months apart so they can have some breast imaging every 6 months. Sometimes they want to do them both at the same time of the year. Both of those are good choices. Now, if you find out that you're extremely high risk, you have a gene mutation like BRCA1, and you might have a risk as high as 80%, then at that point, it really is worth considering something like a prophylactic mastectomy or removing both your breasts. And then, the in-between risk, if you're at 50% risk, for example, it might be worth considering taking a pill called tamoxifen, which is not it's not a pill that's easy to convince people to take because for young women it kind of will throw you into menopause, but taking it actually does decrease the risk of a future breast cancer in half.
That's good to know.
Because
Because I know my friend after treatment is now on tamoxifen for
Yeah.
5 years, I think it is, but I didn't know you could take it prophylactically.
Exactly. And we do use it to treat breast cancer as well, especially for women who are premenopausal, meaning they haven't gone through their menopause yet. We're still having regular periods. We use a little bit of a higher dose typically in that case, and it's usually 5 years or 10 years, give or take. There's different studies kind of saying different things about it. It's a hard medication to take, but it does make a huge difference for someone who's been treated for breast cancer. And for those who are high risk, I think that there's a place for it. I'm not sure if everyone needs to take it. And a lot of times I have women come and talk to me about it, but they're already having some perimenopausal symptoms like hot flashes. And they're like, well, should I take the tamoxifen? And in that case, oftentimes the answer is no, it will actually make those symptoms a little bit worse because it's kind of doing the opposite of something like hormone replacement.
Wow.
Oh, go ahead.
Are there other, I know you mentioned the BRCA gene, but are there other specific genes people should look out for that make them at higher risk?
Yeah, absolutely. So besides BRCA1 and 2, the other genes that I see the most commonly or the most often in my clinic, CHEK2, that's a big one, PALB2, ATM, Those are probably the biggest ones that I see that also increase breast cancer risk. There are about 12 or so right now that we know do increase breast cancer risk, but BRCA1 and BRCA2 and PALB2, which is kind of related to them, are the ones that increase the risk the most. I have definitely tested women who everyone in their family has had breast cancer, and then I've tested a few of their relatives as well, and nobody's had a gene mutation, and then told them exactly that. Like, there is something here, we just haven't figured out what it is yet. And in that case, we still do treat them like they're fairly high risk, because even when you're looking at the history of someone with a gene mutation, you want to see like what their relatives history of cancer is as well. So if everyone in the family was diagnosed with breast cancer at 30, then they definitely need to start MRIs at 25.
Let's talk about, when someone hears the words, you have breast cancer. I can not imagine, but it's a life-altering moment. How do you guide patients in that moment of shock?
So luckily, most often I'm not the one who's giving the diagnosis, and it's actually their primary care doctor or their OBGYN or a radiologist who's giving that information. But on occasion, I've had patients come and see me because they felt a lump, and I was fairly suspicious that it was going to end up being breast cancer. And when I am the one that has to give the news, I really try to take some time and space in that moment and realize that as soon as I've said those words, they're probably not going to be hearing anything else I've said.
Right. Nothing.
And the most important things I get out are really that you have breast cancer, but it's treatable and you're gonna be okay. And pretty much that's all I say in that visit. I just leave it at that. If they have questions for me, then they can ask them, but I don't really go further into it, because I think everyone needs a lot of time and space to process that, and getting that information in the doctor's office and then having to have a whole hour-long consultation about what your options are. It's not good to do those two things at once. And so usually that's kind of how I navigate that. Now, there are some patients who have felt this lump for a long time and kind of already know, and then they're ready to talk about what treatment looks like for them. And in that case, then we do have that conversation. But I really try to gauge the response of the patient and tailor my approach to what works for them.
There's so much talk now about personalized medicine. So how does that really show up in breast cancer in the treatment plans?
It does in a few different ways. So the genetic testing that we were just talking about, there are specific drugs that can be used for patients that we know are BRCA carriers, and we're working on studies for patients who have PALB2 and CHEK2, the other mutations that I talked about. And that's a very personalized form of medicine, because these are drugs that you would only be eligible for if we know that you have one of those gene mutations. And that's kind of the way that oncology in general is going. We're trying to study if these cancers themselves have gene mutations as well. If they have any mutations, that we have specific treatments that we know are going to work better on this type of cancer than another type of cancer. And right now that happens a lot, I think, more in the later stage of breast cancer, but I think that wave is coming to where we're going to have a lot more treatment options for the different types of breast cancer as well, because every cancer is a little different, even if it's the same type of cancer.
What about I think it's probably clear that a lot of these mutations are hereditary, and they run across families. But what about instances where somebody might test positive for a mutation and they have no family history whatsoever? In that case, I know we can speculate all we want. Where does it come from? What is your theory on, people who don't have family history, they're not testing positive for any known genes, and it happens to them? Do you see that a lot or not a lot? What are your thoughts on that?
So there are some gene mutations which can occur sporadically, and like, you could be, you saying, not any one of y'all, of course, but, a patient could be the first one in their family that has it and the first one that passes it on to someone else. That's pretty rare. I do see some patients where I test them and I find a gene mutation and then no one else in the family has cancer. And then I go on to test other relatives and I figure out which side of the family it's come from. Some of these gene mutations, for example, like CHEK2, are not ones that will necessarily cause breast cancer in every generation because they are what we call a lower penetrance gene mutation, meaning that like maybe only 20%, 30% risk of breast cancer if you have that gene mutation. And so something like that can kind of slide through the family and no one knows that they're at increased risk until someone gets breast cancer and then you test them and we find out, oh, actually, a lot of these other people in the family had that as well. So I do see that happen.
Do you feel like breast cancer is more treatable now than it ever has been?
Oh yeah. Oh yeah. Like even if you look like 100 years back, the survival for breast cancer was 5 year survival for breast cancer across all stages was dismal. It was like 20%. And now if you look at 5 year survival across all stages, it's pretty high. You know, it's above 90%. And if you look at stage 4 cancer specifically, and you look at the different treatments and how they're prolonging survival, that's getting better and better and better. And so even for patients who have cancer that has spread to other parts of their body and they're stage 4, at this point, we don't tell them, you know, you have months to live. We tell them this is going to be like a chronic disease, just like hypertension or high blood pressure, and you're going to be taking medications for the rest of your life. But the rest of your life could be years. You know, you could maybe even live a normal lifespan. And that I think that as more research happens, the more options these patients will have.
We were lucky enough to start the month with someone who is living with stage 4 cancer and thriving. And she expressed how grateful she was for how far medicine has come. And she is honestly, the medicine is working for her. She is just enjoying life and she's okay, which is incredible to hear, you know?
It is. And I've seen that a lot, which is, I mean, that's truly a testament to the power of research, but also credit to all of the women who, over the last, especially 50 years, participated in clinical trials, knowing that it may not help them, but it could help the next generation.
You've been really vocal about disparities in breast cancer outcomes, especially for women of color. What do you see are the biggest challenges, and what needs to change?
So I think that there are healthcare disparities for women of color, not just with breast cancer treatment, but especially with things like delivering a baby, getting diagnosed with an autoimmune disease. I think that honestly, all medical schools and residencies need to have some element of cultural competency training because symptoms may look different in women of color than in white women. But also, I think that there's a tendency to dismiss some of the concerns from someone. I think that there's there's a lot of data that kind of shows that for someone who is not of the same socioeconomic class or of a lower socioeconomic class, the disparities are even worse, right? And so I think that a lot of times the story that I see is someone who is from an underserved community who goes to the ER because they feel a lump. And maybe they have a history of going to the ER multiple times because they don't have a primary care doctor. And the ER says, well, this is just a frequent flyer. They just come to the ER for all of their medical care. This is nothing. It was nothing all those other times. This is nothing now. And then that patient feels that lump growing and growing and growing and doesn't really know what to do, goes back to the ER, and then finally gets diagnosed with breast cancer. And at that point, it's a much later stage than it would have been if they had just been listened to the first time. So I think that definitely cultural competency training for medical school, residency, but really for all practicing physicians. I think it should be a really important part of onboarding is making sure that you are hearing women, regardless of what their background, their socioeconomic class, what color their skin is, like that you're really listening and taking these concerns seriously.
100%.
You've spoken a lot about survivorship. And I know you were I mean, it's so amazing that so many people now are able to live after breast cancer. What, besides, the pill that you were talking about, what else does it look like after you've come out the other side?
I think that something that not enough people talk about is the fear that the cancer is going to come back. And that's something that I talk to my patients about a lot, is that, I think that there are a lot of people who will give patients the impression that, okay, once you're on the other side of this, you're cancer free, you're just done. And that's really, unfortunately, not how it works, because you always will kind of have it hanging over your head, like, God forbid, I feel a pain in my hip. Is this the cancer coming back? And that's something that those of us who haven't had to go through breast cancer or any type of cancer will never understand quite how that feels. And that can sometimes be a very isolating feeling, because you're going through these kinds of thoughts and listening to your friends who haven't been through that kind of stuff, talking about things that you might be thinking, well, this is what they're talking about is really not life and death. Like, it's very mundane what they're talking about. And here I am worried that my cancer is back. I think the more time that goes on, and the more that survivors are able to connect with other survivors who are living very meaningfully and intentionally, the less of that fear that they have. And then especially when I love to see survivors get involved in counseling people who are going through and being peer mentors for people who are going through it now, because I think that really helps them with that fear and doubt as well. But it is something that I think never completely goes away. And I think that's an important thing to address when you're talking about breast cancer treatment with anyone.
Do you see breast cancer come back in other parts of the body? Like once you have
Spread.
cancer,
Yeah.
you more.
It spreads.
Unfortunately, I do. The way I explain it to my patients is that even with the best treatments, there's always a chance that there could be one little cell, a tiny little cell that's just floating in the bloodstream, waiting for your immune system to be down for some other reason, waiting to cause a problem, 2 or 3 years down the line.
It is scary.
So scary.
Very scary. You've seen thousands of patients go through diagnosis and treatment and recovery. What have your patients taught you about resilience and strength?
I am so in awe of my patients. They are truly the strongest women, especially in my practice in New Mexico. I really did see a lot of women who had so much other stuff going on in their lives. Not only women who had to deal with intergenerational trauma, but also things like figuring out how to afford breast cancer treatment and still trying to go through that treatment, but also do the job that they needed to keep their health insurance while going through something like chemotherapy. Being a mom, yeah. And that's definitely all of that, I think, it's been very eye-opening. And what it has taught me is that I think that it's so important to have a community of other women. And the women that I see that really are able to get through this without having a lot of other stressors on top of the treatment, financial stressors, childcare, who's going to take care of them, are the ones who have really surrounded themselves with a community of other women, other moms, other people from work and from church and other things like that, places where they can find that community and find other women, because those are the ones who other women are the first ones to jump in and help. They're the first ones to say, you know what, I'll pick up your kid after school so you can go to this radiation oncology appointment. And so that's something that I've really taken to heart. And I try to surround myself with groups of very supportive and caring women. And I think that that's something that everyone should do, especially as they get older, because as you get older, you want to have those friendships, those relationships, but also you want to be someone's support system. You want them to be yours as well.
That really is the theme of the show. That's the theme of the Pudding Pals
podcast. So we appreciate that, and we
It's
know
amazing.
it takes a village. You
Yeah,
know,
I mean, I couldn't get through a lot without these girls.
You know?
These girls have my back for whatever we're going through.
or whatever. And there's a lot at any given moment these days.
You never know what you're gonna wake up to.
It's
I
true.
have a question about screenings. Sorry, we're going a little backwards. It just came to mind. But there's so many. Mammograms, ultrasounds,
Sonography.
what's the
Thermography.
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 Do they show different things? Like, why do you have to do both? There's one thing that can just show all of them, you know?
Great question. So, thermogram, first of all, I would not recommend that for breast cancer screening really at all because it hasn't been FDA approved for that. Studies have shown that it can work, but it's going to catch cancers at a later stage than a mammogram would. And so I think that a thermogram has its uses. It can be used for supplemental screening in addition to a mammogram. And there's very few select patients who, for whatever reason, cannot undergo mammogram. And for them, maybe a thermogram could be a good choice. But a mammogram is definitely a gold standard. I think that is the place to start with breast cancer screening. And most places in the country here in the US, they do 3D mammograms, which I think are a great choice for everyone, but especially for people with dense breasts. The ultrasound question is a little bit controversial because there are some radiologists who really recommend an ultrasound as well because it does show different things than a mammogram. A mammogram will show something like calcifications, might show something like a mass. And calcifications are little white dots, and they often are the first sign of breast cancer. So that's often stage 0 breast cancer. An ultrasound really won't show calcifications, but it would show like a lump hiding somewhere in the dense breast tissue. Some radiologists feel like doing an ultrasound every time with a mammogram for someone with dense breasts is overkill and leads to additional unnecessary biopsies, but some think that it's really a great option to make sure that we can catch everything we need to in someone who has dense breasts. I think that MRIs are a great option for anyone who has extremely dense breasts. So category D breast density, if it says you have extremely dense breasts, I think that you probably need an MRI regardless of what your family history or if you've had a biopsy, because an MRI shows something completely different than a mammogram and an ultrasound and can be a really useful tool for supplemental screening. But for everyone, I think everyone, no matter what, pretty much needs a mammogram. That is the place to start. I don't think that anyone can get away with just doing an ultrasound by itself. That's just not going to catch enough things.
Is there a way to know if you have dense breasts without being told you have dense breasts?
I
Like,
think my
didn't
OB
know-
told me.
My OB told me too, but
Well,
someone
my
who like, can
mammogram
you
told
feel
me.
that you have dense breasts?
I wouldn't have
Or
thought
is it
mine.
something that like is internal and you'd have to like?
So usually you don't feel dense breasts, but it's from a mammogram that you get that information. Now, some states have a law saying that if you do have category C, which is heterogeneously dense breast, meaning part of your breast is dense, but the other part isn't and has fatty tissue, or extremely dense breast, meaning most of your breast is dense, that they have to send you a letter informing you of that and saying something like you may benefit from supplemental screening. And so a lot of times people find out from that. A lot of times people find out because, when they see their OBGYN says, actually the report says that you do have dense breasts. Usually the actual mammogram report, if you have, my chart on your phone and you can pull it up, it will say what the category is. And if your category is D and you have extremely dense breasts, then definitely it would be a good idea to ask your OBGYN about MRIs if they want to order them or if they want to refer you to a high-risk breast clinic where someone like me can order them.
What makes a dense breast? Sorry, I don't like. Like if it's not fatty tissue, what is it?
It's breast tissue. It's working breast tissue, and the whole point of the breast is to make milk and to nourish infants, right? And so it's working breast tissue. That's those glands themselves. That's what makes dense breast tissue. And then the fat usually comes in and kind of replaces that, especially after menopause. But there are some people that I've seen that have dense breasts even in their 70s. And oftentimes it is women who have smaller breasts who have denser breasts.
Makes sense.
So I just turned 40, so I went in for my first mammogram. Very exciting. But there was like an option, and where I went, it was $40, $50. It was pretty nominal to do the ultrasound on top of the mammogram, which I did because I didn't know what else to do. Is that something that you would recommend, or is that just kind of silly that they're just trying to add on for people?
I think that if you have dense breasts, then it's worth potentially doing an ultrasound. I think that it's not something that every single person needs, though. And I think that sometimes mammography places will offer it just to people who they think would benefit from it. Sometimes they'll offer it to everyone. But oftentimes for me, like in my high risk breast clinic, when I'm ordering the ultrasound, nobody has to pay extra for it. It gets covered by the insurance because I'm saying, based on my professional opinion, I think that this patient would benefit from an ultrasound. And these days I do see, though, fewer and fewer radiologists want that ultrasound as well because of the risk of false positives or needing biopsies for things and feeling worried that you have breast cancer when you don't actually have anything wrong with you just because you got an ultrasound and it caught more things.
What about breast augmentation? Does it make it harder? Yeah, implants. But does it make it harder for you to detect breast cancer? Does it change any of your risks?
Not at all. Usually for people who've had an augmentation, they do this awkward thing where they like slide the implant away and do a mammogram of just the breast tissue in front of it. And it's still very easy to look at that breast tissue and see if there's anything abnormal in there. I don't think that getting an augmentation increases your risk at all or makes it harder to detect breast cancers. And people with augmentation should continue to get mammograms.
That's
Do you
great.
think we're ever gonna? I mean, I know you don't have a crystal ball, but are we gonna get to a point where it's like, we detected breast cancer. Here's a pill. You're gonna go home and be fine. Like, can we just be done with this? Like, what? Are we? Can we not cure this? Where is that gonna happen?
That's a great point. I actually think that we're heading in that direction. So, for example, for rectal cancer, in the past, even as recent as I would say 7 years ago, the standard was to remove part of the rectum surgically, which is a pretty extensive operation, after someone had been treated with like chemo and radiation. Now there are actually patients that they never do surgery and they just do the chemo and the radiation sometimes, and then they get a colonoscopy every 6 months just to make sure that this cancer hasn't come back and they're just being observed. And I think that that data is coming for breast cancer as well, that there are some types of breast cancer which respond so well to chemotherapy as well as other types of systemic therapy that they may not need surgery. And then we do something like that where we do an ultrasound of that area every 6 months or something and see if the cancers come back or not, or maybe we even rebiopsy that area and prove that there are no live tumor cells left and maybe those patients don't need surgery. I do think that's coming. I'm not sure if there's going to be just like a pill because there's so many different types of breast cancer, but I do think there's going to be an option in the future, probably within the next 10 years or so, for some people to just take some type of chemo or systemic treatment. It might be in the form of a pill and not need surgery.
If you could change one thing about how society talks about breast cancer, what would it be?
I would change that. I feel like whenever society talks about breast cancer, there's always some impetus to make it that person's fault. And I feel like it happens not just with breast cancer, but with a lot of diseases that impact primarily women, like endometriosis, for example. I feel like people will say something like, well, why didn't she get her mammogram? Why she should have gotten diagnosed earlier. or if she didn't get her mammogram because she's a single mom and she has 3 kids at home and no one to watch them and just couldn't make time to go get the mammogram, they'll say something like, well, she just has too much stress in her life. Like, that's probably what caused her cancer. I even had in my prior practice in Houston, I had a set of grown children try to tell me to tell their mom, who was my patient, that the reason she got breast cancer is because she doesn't wake up early in the morning, and that she's a night owl. She likes to stay up till 2 a.m. and wake up at 10. And they were like, you need to tell her to wake up earlier. And I was like, I'm not going to do that. And please leave. Like, that's crazy. And so I don't understand why it has to be someone's fault. Like, it happened. It's definitely not the patient's fault, right? Like, and trying to find reasons and pin it on the patient in some way, I think keeps a lot of women from asking for help when they need it.
Dr. Jambhekar, we cannot thank you enough for coming on the Pudding Pals podcast, giving the clinical side of breast cancer. It is we're always aware of it, but it's nice that October is the month to really put awareness on it and not to forget it, that there are people struggling out there. So we can't thank you enough for coming on here and helping us understand it, helping our listeners understand it, helping our listeners who are going through it. We really appreciate you.
Can you tell our listeners where they can follow you?
Yes, your TikTok.
Yeah, she loves your
Yeah,
TikTok.
I love your TikTok.
Thank you. So I'm on TikTok, AJ Victory MD. Post the same kind of stuff on Instagram and Threads as well, and a little bit on YouTube.
Awesome. Well, thank you so much.
Thank you so much.
Thank you for the invitation.
Guys, she was so great,
Informative.
so informative.
She's so smart.
so smart, so pretty.
I'm just so glad we could end Breast Cancer Awareness Month with her and really just giving people the clinical, facts and how, prevention, detection, and what to do.
And
So
it's nice to hear that it is more treatable.
Yeah.
And it's
Yeah.
better.
There's
She had
So
such
comforting.
good information
There
to
is
share
hope.
with
You're
people.
right, Steph. There is. All right. Well, let's play our game.
okay.
All right.
Hands up, girls.
Hands up. Okay. Never have I ever lied to my doctor about how much I drink on your form. Oh.
I mean, everyone has.
I mean, how do you write
One.
one drink?
I always say 1 to 2 drinks, maybe socially. If you use the word socially a lot. It's social. It's social.
Never have I ever skipped a checkup for over a year.
Oh, me.
I know.
But I would never do that
We
now.
just talked about this stuff. I made her get her blood drawn and she
Yeah.
did it. Never have I ever avoided going to the dentist for way
Oh
too
my
long.
God, me for like 4 years, and I had like
Not
15
the
cavities.
dentist.
Ew, Jordan.
Disgusting. I was
go every
so.
6
That was also an issue you had this year.
That was the beginning of the year issue. Lots of issues this year.
Never have I used expired medication.
Oh, me.
Oh,
All the
definitely.
time.
I just threw away from
Have you guys seen
2023.
my cabinets?
There's suggestions.
Yeah.
Never have I ever thought water fixes everything.
Water is very good for you.
Kevin,
I don't think it fixes
I will
it.
say
I don't
to
think
Kevin,
water
I have a
fixes
headache.
shit.
Drink water.
Yeah.
I don't feel good. Drink water. Like, no.
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 I do that to the boys.
Advil.
You're grouchy because you haven't had enough water.
Jordan takes a sip of water with her pill. That's the water
Advil.
that helps her.
Yeah.
Never have I ever tried to stretch and pulled something.
Oh, me.
Definitely.
Uh,
Oh, she's out.
you're out, Jord.
All right.
All right. Dare to dip or spill the pudding?
What do you guys want me to do? Spill the pudding?
Whatever you
Let's
like.
go.
I'll spill the pudding.
They're next to you, Steph. It's on the double card. Yep.
Okay. What gross food combo do you actually love?
What gross food combo do I actually love?
I mean, I don't know if it's gross, but like I like pizza with
Olives and pineapple.
You love mayonnaise on
Ew.
everything.
Olives
like
and
pineapple
pineapple.
on pizza.
On pizza.
Yeah, olives and pineapple
So
and
that's
pizza.
not gross,
And yes,
that's
Heather
weird.
is right. I can spoon mayonnaise. I love mayonnaise. I live for mayonnaise. My husband is disgusted about it. Oh, plain. I love mayonnaise. Such healthy.
What brand do you like?
Oh, the best.
Best
No,
Foods?
I
That's
eat
the best one.
foods, but right now I try the Primal Kit. I do the Primal Kitchen.
Jordan, I could teach you how to make homemade mayonnaise.
You guys, I could eat
You might not wanna eat it.
mayonnaise on. I dip chicken in it. I dip
didn't know
crackers
that
in
about
it.
you.
I love mayonnaise. My
Wait,
dad was
could
the
you
same
take
way.
the tube and go?
Oh yeah, I could just.
Ew!
Remind me of Patty mayonnaise from Doug.
Jordan.
You guys, I love mayonnaise. I don't know what to tell you. I'm never gonna change.
That is gross.
Listen, girls, that ends this episode. Go have some mayonnaise. Also, like and subscribe.
Don't forget to do your self checks.
Get your self checks. Get your yearly mammograms, and we will see you next time on the Pudding Pals podcast.
Bye.
Bye.